Okay, hey guys. So we did cover before problems that can happen here at the mitral valve. Right now we will go into the next important valve here, which would be the aortic valve. So we'll start with stenosis, and stenosis meaning that it's not allowing the blood to go easily through the valve. So obviously when that happens during the systole, and in which during the systole, as you all know, there will be increase of pressure inside the left ventricle, also in the right ventricle, but we're focused now on the left side, right? And so the pressure is going to build up. There is no way that the blood is going to go back this way, right? Because we have good valves here that are closing, unless they're also defective. But if they're closing, then that will produce to us the first heart sound. Good. The pressure is going to continue to increase until it exceeds the pressure inside the aorta. So there will be a slight delay from the first heart sound till you start hearing that noise, which will be the next murmur. And so the murmur will look something like that, and then will continue, will keep going, and will fade a little bit towards the end till the second heart sound. And so it will be almost pan-systolic murmur, but it's a sharp murmur, and it's a very strong, it's very loud murmur. And it happens during the systole. Why the systole? Why not the diastole? Well, because it's happening because of the blood passing from the ventricle to the aorta. So it makes sense that it's happening during the contraction of the ventricle. Contraction of the ventricle, we called it the systole. So therefore, this is a systolic murmur, right? Okay. So the blood is not going as fast, as rapidly into the aorta, right? So obviously the pressure inside the aorta, especially the systolic pressure, will be slightly reduced. So maybe you are looking at something like 100 over maybe 60 or over 70, right? The pressure will be less because now less blood has been passing from the ventricle. Of course, the heart will try to compensate, so there will be hypertrophy. You will try to squeeze more blood. You will increase the contraction, the contractibility of the cardiac muscles in order to overcome that resistance. It's not like, okay, the ventricle is going to give up, right? But with the more ventricular contraction, then the sound is even louder because now the blood is really going, like I said, in every direction, and they will start to vibrate the aorta, and the vibration of the aorta will give you this noise, and you can even feel the noise with your hand, and we call that a thrill. Sounds good? Where will you feel it best? Well, wherever you can feel or you can hear the second heart sound, the aortic component of the second heart sound best, and that will be in the right second intercostal space, right next to the sternum. So next to the sternum, second intercostal space on the right, that will be where you will be hearing that murmur the loudest. Sounds good? So that when it is stenosis, right? And so let's describe then what that means to us systemically, other than the noise that you will hear. We already described what happens to the blood pressure, but let's see here what happens when the pressure inside the ventricle is backing up. The ventricle is not able to empty as it should, right? And that will result in the atria not being too empty as fast as, I keep getting those emails, as fast as it should, right? And that will mean that the pressure is also building up inside the atria. And the building in the atria will mean that your lungs will start to back up as well, causing pulmonary hypertension. So you have difficulty breathing, you have pulmonary edema, you have you're coughing blood, but the pulmonary hypertension is now going to create a backup pressure on the pressure that is on the power of the right ventricle to empty. So that means right ventricular hypertrophy will kick in because now the right ventricle is going to try to work harder to push against the pulmonary circulation, right? And so now you have high blood pressure, high pressure inside the right ventricle, and that will result in higher pressure in the right atrium, and that again will back up into the superior and inferior vena cava, right? Good. So that was an example of aortic stenosis, right? Well, let's see what happens if the problem actually in the valve not closing properly. So you have incompetence instead of stenosis. Passing of the blood, in theory, it shouldn't give any noise. I will tell you why towards the end of this video, why in theory, right? But in theory, the blood is passing gently, as it should, but on its way back, you remember that this valve is supposed to close, creating to us the second heart sound, but it doesn't close completely, so the second heart sound will be slightly reduced, just slightly reduced, and then the blood is going to come back, right, from the aorta to the ventricle. And some of you will say, well, wait a second, why would the filling of the ventricle create sound and not the filling this way? Well, you have to think of it this way. The filling of the ventricle from the atrium, the normal filling, is coming from a pressure that is about 8 to a pressure that's about 2. So the gradient of the pressure is about 6, right? But the gradient pressure we have here we're going to have maybe 60, 70, right? Which is during the systole, right? And now that's the pressure inside the aorta, and almost a 0 here, right? So now the vibration is coming, the gradient difference is much faster, and the blood is coming screaming into the ventricle, causing shaking of the ventricular muscle. But when is that shaking supposed to happen? Well, that shaking is supposed to happen after what's supposed to be the closing of the second heart sound. So immediately after the closing of the second heart sound, you're going to start to see some noise that fades with time like that. So it's early diastolic murmur. Early diastolic murmur that will be due to the backflow of the blood from the aorta back into the left ventricle, right? Why diastolic murmur? Well, the ventricle has to relax in order for the blood to go from the aorta back into the left ventricle. You remember how I told you only theoretically during the contraction of the ventricle, I'm going to change the color here. So the blue will be during the contraction now of the ventricle. The yellow is during the relaxation, right, the diastole. But during the contraction of the ventricle, now the ventricle is supposed to push the normal amount of blood plus the blood it came back, right? Plus the blood that came back through the aortic valve. So now you have more blood. But remember that the valve didn't get bigger, it just failed to close. But you have now more blood passing through a normal size valve. So it's going to start to create noise. It's almost like the door is supposed to only have 2 people side by side, but now you have 10 people passing, right? And so it can generate some kind of a softer murmur because now it's relatively closed, but it's not defective. It's just because of the amount of blood passing through has increased, because now the amount of blood is the atrial blood plus the regurged aortic blood, right? And that will create to us some kind of noise as the blood is going back to the aorta. Sounds good? Okay. So those are the sounds. Again, it will be diastolic murmur, early diastolic murmur. As soon as the valve is supposed to close, you will start to hear that noise. It's not like the mitral stenosis, where you waited a little bit and then you started to hear the noise coming up, right? So we agreed to this, right? Okay. So what does that mean systemically? Systemically, what does it mean to us? So let's have a look at the blood pressure here. So if we agreed that the blood pressure of the ventricle goes down during the diastole to close to 0, right? Close to 4-0, right? And so if now those two are connected, especially if the defect is big, right? So that means the aortic pressure will drop very much because now it is connected to that of the left ventricle. So whereas the systolic pressure inside the aorta will be maybe 80 or 90, right? That is the systolic pressure. The diastolic pressure can be as low as 6 inside. It's a really bad 6. 6 inside the aorta. Why is that? Because you are connecting the aorta with a relaxed ventricle. Usually there is this, or normally there is this valve which prevents them from being connected to each other, from the blood returning here and having the same pressure as the one we have in the left ventricle. But since we don't have a valve, the pressure inside the aorta and the pressure inside, especially in large defect, not tiny defect, a large defect will result in the pressure inside the aorta and the pressure inside the left ventricle to be almost equal, and therefore now you have a very big gap between the systole and the diastole. Sounds good? So that's the systemic pressure. Obviously the perfusion of the tissues with this kind of pressure is ridiculously low, because the mean arterial pressure will be very, very low, and the person will be always tired, fatigued, and that's on the systemic arterial side, right? And so, but the same thing also can be said for the backing up. Remember, now you're not able to push the blood. Why is that? Because everything you push, you get a third back. You push it, you get a third back, right? Or more or less, depending on the defect, right? So it ends up that there will be backing up of blood here in the left ventricle, and the rest you know. If the blood backs up here, then it will back up here, creating increased pressure inside the left atrium. That will increase the pressure in the lungs. We call that pulmonary hypertension, coughing blood, all of the stuff that we talked about, and not being able to breathe. You have cyanosis, you have dyspnea, and pulmonary edema. You go from here into backing up in the pulmonary artery. That causes increased pressure inside the right ventricle, which on the long term it can cause right ventricular hypertrophy, which if uncompensated it will give congestive heart failure, and that will result in the right atrium not being able to empty. And the same thing, the right atrium was draining from the superior and inferior vena cava. Well, that is now going to be hindered because the pressure here has also been elevated, and therefore you see the jugular pulsation, therefore you see systemic congestion, you will see lower extremities edema, you will see portal hypertension, and the stuff that we talked about before. So that's an example here of problems that can happen in the aorta, both aortic stenosis and aortic incompetence, and we see the difference in the timing of the murmur, the type of the murmur. One of them is soft, which is the regurg is soft, and the stenosis is sharp. The stenosis, it will be during the systole, during the emptying of the ventricle, whereas the regurg or the incompetence will be during the diastole or the relaxation of the ventricle, and therefore the blood rushes back from the aorta. And this is the clinical case that I told you in class that I had many years ago, and where the patient had a very severe defect in the aortic valve, and his pressure was almost those levels that you see here before you. Sounds good? Okay, so these were defects on the left side, and if you take that to the right side, you will probably have kind of the same thing. The timing, the systolic, the diastolic will be exactly the same. The place where you hear them will be slightly different than the place where you hear those best, but the backing up will be the same thing. The only difference is you're not going to have any backing up in the lungs when the problem is on the right. You're not going to have any backing up in the lungs. The backing up will be in the systemic circulation, but you're not going to have any backing up in the lungs, right? But try to figure out on your own now what's going to happen if you have tricuspid stenosis, if you have tricuspid incompetence or regurg, and the same thing for the pulmonary stenosis, pulmonary incompetence. There is another kind of defect that is children can be born with, and that is it's called patent ductus arteriosus. Also, you can have here a defect in the septum, so atrial septal defect. Atrial septal defect is not going to make any much noise, because remember, the pressure inside those is almost the same, and there will be a problem with the oxygenation of the blood, but don't expect that there will be noise coming from this what we call the foramen ovalis, the hole between the two. Whereas the aorta and the pulmonary artery, they have a duct that connects both of them during childhood. You don't have to remember that, but it's called ductus arteriosus. And if the child fails to close this duct, obviously the blood is going to go from the aorta, which has the higher pressure, into the pulmonary artery, and so that will create almost a constant, we call that like a train sound, a locomotive sound that will drive the blood with every heartbeat to the pulmonary artery. And that's a serious situation, but luckily the treatment is kind of simple for the patent ductus arteriosus. Okay, we're going to focus on the valves, the heart sounds, so play with those. Try to understand what happens if one valve is defective, one valve is doesn't close all the way or closes too much and therefore it's stenosed, and you will be able to appreciate all the murmurs that we covered in those 3 videos that I just posted for you. All right, have a great day.